Washington State University. Go Cougs!
So here's, yeah.
Can you tell us about how long it takes you to get to the point where you feel like you have a good idea of a person's pattern in their data and are able to be starting to pull this information out?
So I would say that it takes probably around 10 to 15 hours of reviewing a single person's data before I feel like I really understand what their patterns look like in the data. That's, I would say, in the beginning. Now I think I probably almost cut that in half, but I'm learning to really use the nursing information that I elicit on the interviews I'm using that to very much inform exactly where I go in the data now. But if I didn't have any of that, like some of the Horizon House ones that I just went in and was looking at, and I didn't know these people because they were in the study long before I was even an IGRT fellow, that took a lot of time to really understand the profile of that person. But once you understand it, then you can really easily start looking for anomalies. And that's the important piece, is looking for the anomalies. So if we are concurrently collecting raw sensor data and collecting nursing assessment data side by side, then it's very easy because we can use the fact that the patient told us they fell on, at 1:40 in the morning last Thursday night. This was their downtime. This was the time that it happened. This was where it was happening. It's very easy to go in the data and find that. What's harder, yeah.
How many days of data do you need to find a pattern?
What's that?
How many days of data for each person do you need to find a pattern? For example, 1 week of data?
I think 1 week. I think you could pretty much see it if it's a normal week. If it's a weekend, if it's a holiday, if family's in town right now, that's not a good week, right? You have to know you have to be smart about what week that you take as that norm. And if there's other things going on in that week, which you would want to elicit from the participant, then you're either going to need to extend that or pick another slice of data to look at.
So 1 normal data.
Yeah. Yeah. Okay, so here's a second example, and I'm going to go through this one a little bit faster because you kind of have the idea of how this works now. This person is an older female who has shortness of breath. She actually has osteoporosis so bad that her chest wall, so the bone structure of her chest wall, is collapsing in on her lungs. Okay, and so she is currently on 5 liters of oxygen, which is a pretty high pressure for the oxygen thing that they put in people's nose. It's called a nasal cannula. That's a pretty high pressure for a nasal cannula. At 6 liters in the ER, we switch it to a mask because we are at the point where we're putting so much pressure in the nose, it's just coming out your mouth. It's not doing any good for your lungs, okay? So it's pretty, she's got some pretty significant lung stuff going on. We have her diagnosis that we look at. We look at her H&P. We know that she's having breathing issues because she does pursed lip breathing on exertion. So when she gets up and walks to the bathroom, she's doing this. Okay? She's in a downward trajectory as well, so she's getting worse over time. Her resting respiratory rate, not on exertion, her resting respiratory rate is 28. Normal for an adult is 12 to 20. Okay? So she's above that. And then she's more than double the normal rate when she's up and walking around. In fact, her oxygen saturation, most adults with no lung issues are anywhere from 98 to 100%. Pretty much nobody's 100%. Everybody runs about 98, 99 if you're in really good shape and good health and don't have lung issues. If you are, I should have brought a pulse oximeter to pass around because it would have kept you entertained while I'm talking. But you could take your own pulse oximeter, your own oxygen saturation, and hold it until it gets down to 90 or 89, and you want to gasp for air. When you have that on your hand or on your finger and you hold your breath that long, you are just dying to take a breath of air. She normally runs at 89 to 92 at rest. When she gets up to the bathroom, she drops into the 70s. That puts her at risk for instant cardiac arrest because there's so much oxygen demand on her heart, it can't keep up. So she's a pretty sick lady. So we keep all of this on her. She's on different medications. She's on medication for anxiety. That's lorazepam, which I would need to be on if my oxygen saturation was that low. I would want a hefty dose of that. And then she has the pramipexole, which is for restless leg syndrome. It's also a drug we use for Parkinson's, but she takes it for restless leg syndrome, okay? So her routines have changed. She used to sleep in her bed. Then she started sleeping in her recliner. But recently, post making the slide, she's gone back to her bed because she has a new bed and they've increased her dose of the pramipexole for restless leg syndrome. So the things that I'm using on her are listed here with the asterisks. It's the same group of measures that I have just learned to use, either from looking in the literature or from relying on my clinical expertise. So with her, definitely walking speed, because she's going to be slower because she can't breathe while she's walking, right? So she, when she's in bed, she sleeps here. She comes out to the hallway and into the bathroom. And then if she sleeps in her recliner chair, it's here, and she'll come through here and into the bathroom. When I look at bathroom use or walking speed, I like to go from the bed to the toilet or the recliner chair to the toilet, and I like to do it at night because there's going to be less variability than if I look at that measure during the daytime. Does that make sense?
So, Shelly,
Yeah.
is there, I'm just like looking at the setup of both of these homes, is there a reason that they keep the bathroom like separate? So it seems like it's, you know, they have to get up a lot at night, that it's far away from the bedroom, they have to come out, you know, through two doors and.
Yeah.
I don't know.
Why did they design it that way? I mean, it's a really good question, except that I do know that all of my participants, they're independent when they're in this area. So it's not an assisted living where you would definitely want the bathroom right not too far from the bed. But it gives a place for guests to go to the restroom when the grandkids are over visiting, that kind of thing, versus having to go into grandma's or grandpa's room and then into the bathroom. I'm guessing.
Yeah, that would probably be the logical thing, but
Yeah.
just thinking how
It
often
is.
they have to do that.
Yeah. And when they're in decline, I mean, eventually it gets to a place where they can't do it anymore.
A related question to
Yeah.
the walking speed. Do you rely on knowing how big their apartment is? How do you calculate walking speed?
Yeah, I do rely on, from a clinical standpoint, understanding if it's taking them, 50 seconds on average, 55 seconds to go from the bed to the bathroom. If I understand how many feet that is as a nurse, I can kind of understand, how far into decline they really are. But ultimately, when I'm doing that calculation, I don't think that the distance matters because the distance is the same no matter what. They're going from the bed to the toilet.
Looking at changes.
I'm just looking at the change.
Oh, okay.
Yeah. So their distance doesn't change, but the amount of time it takes them to travel that distance changes with changes in health states. If that makes sense. So these are the areas that I would be focusing on with sensors going off in these areas. And if I'm looking at walking speed, I'm not taking into consideration what's going on with these sensors. So I have developed my own, I'm sure, very simple ways of calculating that, so that if I provide information to Dr. Cook's team, I can say, yeah, I know this person's walking speed has declined over time, because I can transfer some of this data into an Excel spreadsheet and then just sort, and then look at, do simple subtraction calculations. I always say I went into nursing because I wasn't great at math. I can move a decimal point for epi in the correct direction, not the right direction, but the correct direction, and I can do some subtraction. The rest of my expertise is in intuitiveness and experience. So with this person, one thing that we lay alongside that sensor data is what's going on with her medically. And one of the ways that we can slice that data is by looking at her prescription for oxygen. So in November, when she enrolled in this study, she was on 4 liters of oxygen by nasal cannula all the time, whether she's at rest or whether she's walking, okay? In December, she was changed from 4 liters at rest to 5 liters while walking. So she doesn't get that such a low. She was actually dropping into the high 60s while she was walking at that point. She is one tough lady, let me tell you. She raised 9 children. She's got to be tough. 4 about did me in. January, she was 4 liters at rest and 5 while walking still, but towards the end of January, actually, and throughout February, she's at 5 liters at rest and walking, and on into March. So we can compare the sensor data with this, and then we can compare that with sleep location. Because what might you do if you couldn't breathe? Would you want to lie flat or would you want to sit up? If you can't breathe, what does your body want to do? Your body wants to sit up, right? So we can actually see that she went, when she was right in this period of time, that she went to, from her bed to sleeping in her recliner chair because she could sit up. As a nurse, that's really clinically relevant to me because it tells me about her. I don't even have to have a pulse oximeter on her to know what her oxygen saturation is. That change in sleep location tells me that an intervention is in order. She either needs a change in her prescription for oxygen, or she may need a further assessment beyond that because she may have caught an upper respiratory infection because she's at risk for that, because that air pressure always in her nasopharyngeal area puts that mucus tissue at risk for infection, okay? So that's really clinically relevant. So here is, real briefly, I had a nursing student that was an RN to BSN student. She'd been an ER nurse for, I think, like 11 or 12 years when she was in my class, coming back. So in nursing, the entry level to practice is an associate degree. It's one of the few degrees you can go to college for 2 years and come out and make 80 grand a year. So a lot of people want to do it. But hospitals are wanting nurses to go back for their bachelor's and their master's now. So she was sort of being pushed to come back. But so she analyzed this data with just a ton of clinical experience. And I love having those eyes on the data because I learn a lot also from nurses who are clinically experienced as well. So these were some of the measurements that she did. And you can see how she switched to sleeping in the chair about the same time when we needed to increase her oxygen, about the same time the doctor increased her oxygen. And she just did simple calculations on the movement and her walking speed from bed to toilet or from chair to toilet. And there's quite a bit of variability in here, so it's not a great representation, but it's what we have. And you can kind of see in general how her walking speed is increasing before her oxygen is increased, and then her oxygen increases and her walking speed decreases. Makes sense, right? And then slowly that's going to increase over time again because remember, she's in that downward trajectory. She's in decline. So here's sort of the relationship. We have increased oxygen with increased walking speed over time, and then a change in where you're sleeping. Those are the clinically relevant things we look at. And these are things we can see in that raw sensor data. So one more example, restless leg syndrome. This one's kind of interesting, and I'm still in the early exploratory stages of this, but this is a person who is the same person with the oxygen issue. So the respiration's at 28 per minute, and she's on the pramipexole for restless leg syndrome. But restless leg syndrome is actually a really big deal. There are a lot of people who suffer from that. Do you guys all know what restless leg syndrome is? Some of the younger people don't know what restless leg syndrome is yet. You haven't had enough stress in your life to have all that build up in your legs, and your legs sort of jerk at night, so that, you know, they just jump, basically. Well, for a huge portion of the population now, this is a pretty major issue, and I think it's a lot of people don't exercise, that really helps with it, and stretching and that kind of thing. We have more sedentary jobs, a lot of people do. But anyway, she suffers from that, and it can really deprive people of sleep. And sleep deprivation has huge health effects. That's why sleep studies and sleep labs you're seeing them emerge everywhere in every town in America. So here is, again, where she sleeps. We're going to pay attention to just the bed area. So here's an example of where we have bed direct sensors and area sensors firing intermixed over a period of time. What I want you to notice about this data is the fact that, let me go back here. This is all within a single minute, and then coming down to another minute. So this is like a ton of sensor fires within a single minute.
And for those of you not familiar with the infrared motion sensors, they will go on when there's movement, and then they stop when there's cessation of movement. So it's not just that you're there, but you're moving.
But you're moving.
Normally, it could actually be an hour in between in some cases.
Yes.
Motion sensor that when you're
Especially at night when you're sleeping. We should see quietness of the sensors. We shouldn't see this much activation. So I believe, based on her complaint of restless leg syndrome, and I interview my patients, and so I know which nights they really had issues with restless leg syndrome. And in this case, she had several nights of it. Here is another section of data representing the same thing. And here's her in the living room chair. In this one, you can see there's some more silence. You can see the changes in the minutes. There's not nearly as much going on. Here's 30 minutes of quiet sensors. This is what we would like to see to know that somebody's doing better with their sleeping. She actually had her restless leg syndrome medication, the pramipexole, dose doubled. And in this case, it was really interesting. I will actually claim, because I was doing her home visit right around this time, and I was looking at her data, and she was complaining about it, we were able to facilitate a change in the order for her medication based on this work. And we have proof that afterwards she's sleeping much better. So that's kind of exciting. That's closing the loop. That's the true clinician in the loop piece. So just to finish off here really quick, I look at the transcripts with the nursing data. So in qualitative analysis, normally we are looking at an interview that somebody has typed up that is verbal language. And really what I'm doing is just taking that transcript and making it my raw sensor data, okay? We look for rich text or standout text. I'm applying that tenet of qualitative analysis to this, looking at sensor combos and quietness of sensors, and then I pull out common themes. And those themes are the measures that we talked about, and they're supported by different characteristics. And here's just a snapshot. There's more than this, but this is just a snapshot. Interestingly enough, there's a couple of things I'm noticing around wandering. One is macro wandering. This is not written about in the literature, but it's a really kind of cool thing. When someone is early in cognitive decline, and this is based on the work with the 4 or 5 Horizon House people that were clinically diagnosed as having dementia, early on in the process, they might have a room in their house, like an office, that they really never go into. Like you can see, they're basically never in there. And as they're in early cognitive decline, they start going in that room, just randomly. They're not in there long enough to accomplish anything, but they're starting to randomly go into that room. And then this was across 4 people, or 5. Then they're using their whole house, including this room. Then they moved, I call that macro wandering, okay? Inclusion of a room that you normally don't go in, but now you start to go in a non-purposeful kind of way. Towards the end, when they were no longer in the study because they either moved into an inpatient residential care center or passed away, to micro wandering, which is now we're not only not using that room that we started using, but we're also not using rooms that we always used, like the kitchen or a particular bathroom. Maybe a home has 2 bathrooms and both bathrooms are used all the time, but now there's only 1 bedroom and 1 bathroom being used and very little or no kitchen use. The change from macro wandering to micro wandering, I mean, I think there's something there. We have to do more exploration around that. I'm going to skip to, because I think repeated behaviors and time comparisons are pretty easy to understand. I talked a lot about sensor activations. Daytime rest is easy to understand, but this idea of bookends is evolving in my thoughts, but where I'm going to share with you where I am right now is it's pretty clear to me that when I look at a health event and I identify what the start and end of that is, based on what I see in the data and the report from my patient, that the data that bookends either side of that event, it's not normal, like further out, but it's not the event either. And I think that that set of data probably needs to be the focus area in the future. So talk about future research. I think that bookended data, if I can start to see it, we can probably train a computer to start to see it. And that's the answer that I'm looking for as a clinician, because I want to be able to proactively intervene, or at least get to somebody within a reasonable amount of time, and not reactively intervene when you're already in my ER. So if we can proactively intervene, we can change people's lives. Okay, lots of limitations to this. It's a neoteric work. There's not a lot of literature on this area. There's no literature on this process except the paper that was published this summer that Dr. Cook and I published. It's interesting because it's qualitative analysis of quantitative data, but I think it's the future of, if we're going to develop artificial intelligent algorithms that really work and are context aware, my understanding is you need a good working theory that has to be provided by a human. And in this case, if we're going to look at clinical changes in health states and clinical relevance, I think nurses are really well positioned to provide that information. And of course, that's my campus.